everybody. This is Dr. Gwilliam here with ChiroCode. I'm here with Jeff Smith, and we're going to do this special show for you today. Before I turn the time over to Jeff for just a moment, I want you to know that you are all muted, as you may have noticed, but Jeff and I are not. And so we'll be talking at you and to you for most of this. I encourage you to submit your questions in the question toolbar that you should see on the right. You can type them in as we go. We may save them for the end, and then at the end, we're hoping that because of the group size, we can unmute everybody and we can have you verbalize your questions. It gets a little hectic when we do that, but we're going to try it out so that you'll have that chance. So I'll turn it over to Jeff and let you make a few announcements, and then we'll dive into the stuff I've got prepared for you today.
All right, that sounds good. Well, and good to have you on this webinar with us, Dr. Gwilliam, and welcome everybody. You know, Dr. Gwilliam did a webinar a couple of weeks ago, and he touched base on this, you know, the topic of demonstrating the chain of medical necessity, and went into a little bit of detail on that. But I really wanted him to do a deeper dive into this topic, and you know, he'll touch base on this as he goes through the webinar. But you know, for a while, we've been obviously most concerned about our Medicare documentation, but we are starting to see signals where the private payers are starting to do some audits as well. We've had some Cohesion members that have had some audits from private payers, and Dr. Gwilliam can speak to some of what he sees around the country. And so I thought it was really important that, you know, that we get an expert like Dr. Gwilliam to come on and give us his perspective and give us his knowledge and his education and his experience and share that with us, but also then allow you, the doctors, to ask questions as well, and in this forum. And so that's why I'm glad that he agreed to be with us today. And with that, as Dr. Gwilliam said, if you have questions, you know, go ahead and use the question box. And then when we get to the Q&A session at the end, he'll unmute everybody, and you'll be able to ask questions, you know, through the audio as well. So with that, Dr. Gwilliam, take it away.
All right, thanks a lot, Jeff. You guys should know Jeff and I have been friends for several years now, and you're fortunate to work with him. He's a pretty smart guy, and I appreciate his input that he's helped me with things in the past too. I'm excited to share this with you because there's some stuff that I put into this presentation that's relatively new, in that they're concepts that I sort of formulated in the last few months, and I did present it in a webinar a few weeks ago, and that's what prompted Jeff to set this up. But I think these are a great way for you to look at your care and your relationships basically with payers and figure out how to get the most out of them and improve them. My goal is to teach you what the outsiders are looking for when they look in at your records and your billing. And so if I can help you get that perspective, it should allow you to craft the way that you document and bill in such a way that it should minimize complications for you, that you should simply be able to do your work, convey what you need to the payers, get paid properly, and get back to your work, you know, and take care of patients. So that's my goal with you today. Just a little bit about my background. I have a couple of degrees with business emphasis, and then I'm a chiropractor too. I got some good grades, have a bunch of certifications. And really, as far as the certifications go, I really just want to point out a couple of things here. I'm a certified professional coder, which means I know coding, medical coding, pretty well. I'm also a certified professional medical auditor. And that basically was a course I went through and a hard test I took about auditing medical records. And I've used that a lot in the last several years, and I do a lot of that work through ChiroCode and also independently with some attorneys and other things when necessary. I just got a chart I was looking at this morning before this presentation, and I've got the doctor sent me a bunch of records for a patient, and I'm going to go through and try to cut it to pieces and tell them how they can improve it. And it's a educational audit. I'm not even, you know, they haven't gotten in trouble with any payers. They're not trying to defend themselves. They just want to get educated so they can fix things. So that's something, if that interests you, let me know. But the concepts I'm sharing with you here are based upon that. Well, they're part of that whole mess. I mean, what I'm sharing with you now is what I would share with you if you were my client and I sat down with you and I said, hey, your records are messed up here, they're pretty good there. And so that's what I'm going to do with you today. All right? And really what I've done is based on my conversations with Jeff, is we've picked the things that he feels that are the most critical. So we're going to kind of do a deep dive into these concepts, and you got to understand that these concepts are not. I didn't just take Medicare information and restate it for you. What I've got here is my own interpretation as a so-called expert of information I have seen as I've been dealing with my clients and attorneys and others who are either getting post-payment reviews or audits and other problems they're dealing with. And so I try to simplify it and make it easier to understand. So I've decided we're going to talk about 3 concepts here today. We are going to talk about the episode of care journey. And I'd like to say this is a kind of new concept to chiropractic, but it's not really. It's just the emphasis is pushing more and more this direction. In fact, I was reviewing some of the old reports from the Office of the Inspector General about a month ago, and there was one from a decade ago where they said, look, when Medicare reviews chiropractors, they need to look at the entire episode of care, not just at a single visit. Like that was a recommendation from the Inspector General to Medicare. And so this episode of care concept isn't new, but it's being emphasized more. That's a trend I'm seeing through my work experience and the contacts I have, is that the episode of care is more and more important than it ever has been. All right, and I'll share with you how to convey that and what it means. And then we're going to talk about the chain of medical necessity, which is really the heart of this presentation. This is also my own concept, I should say, that I've developed over the years. It began as part of the Chiro Codes book, which I co-write with my team. And I came up with this idea of, okay, if you could just take a simple recipe or a little checklist and apply it to any service, what would it look like? And I had last year it was 4 elements in this. I called it a recipe for medical necessity. But then more recently, I revised it and came up with this chain of medical necessity, which has 6 links in it. And I think you'll find it useful and an insightful way for you to look at your services to determine whether or not they meet medical necessity criteria. And then the third and final topic we'll discuss isn't quite as critical as the others, but we're going to talk about diagnostic codes a little bit and their role in medical necessity, because I think they're overlooked, and I think if you use them properly, you'll be able to see how they can help your cases stand up to scrutiny. All right, so those are the 3 concepts I'm going to cover with you, and I think you'll see how they kind of all tie together when we come back to the end here, okay? Now, the next couple slides here, what I've got is some various documents, and this is a little messy looking. It's because it was a PDF that I received, and I just did a screenshot of it, and I stuck it into my PowerPoint presentation here for you. This is a denial that I was working on with a client from Aetna. Aetna does these. Aetna is one of the big insurers, right? And one of the things I like about Aetna is they have volumes and volumes of information about why they deny things. So they've at least documented all the things that they won't pay for, and that's one of the things that makes Aetna a little different from the other payers. Sometimes they'll just deny you don't know what's going on, but Aetna will explain themselves thoroughly, in fact. So I found this insightful. I wanted you to understand what it means. And I know I'm quoting one insurance company, but I want you to think of this in the bigger scheme of things. Just think of this as any outsider looking in at your records. So in that highlighted section there, I've got, when no improvement is documented within the initial 2 weeks, additional chiropractic treatment is considered not medically necessary unless the treatment's been modified. Then it goes on to say you got 2 more weeks, and if you can't show some clear improvement in 30 days, then you're toast. We don't pay for anything. Okay? So my point is that they're not looking for a single visit. They're looking at this period of time, 2 weeks and 30 days, and they're trying to figure out if that during that episode there's progress, okay? And if they determine there isn't, then they could throw out everything during those 2 weeks, which could be, half a dozen visits potentially. So that's just one payer's viewpoint of this kind of episode of care. Now, this snippet here is also a screenshot. I pulled this from the proposed Medicare LCD, and depending on where you practice, you may or may not have this finalized yet, but the anticipation is that this is a change to Medicare's guidelines, and it's expected to be standard nationwide. And I think it has been adopted in a few places. Basically, the deal is this is where Medicare says for chiropractors, here's how you need to document subsequent visits. And until they came out with this document, there was only 3 elements. And you can see here in the list that there's 4. There used to be 3. And now they've added a fourth one. I highlighted it there for you to enjoy. The fourth one is documentation of how the day's treatment fits within the plan of care. And they give the example of visit 4 of planned 7 treatments. So what they're looking at is an episode of care that covers 7 treatments, and they want to know how this visit fits within it. And they're asking chiropractors to now document the visit number. And if this is news to you, then I would simply advise you to begin to add this, because it's going to become mandatory, most likely. And it's just a good idea, right? What they want to see is not so much that you have patients who show up and then you treat them until they disappear and you have no plan or outcome or goals in mind. What they want to see is that you said, okay, based on this problem, I think they need a dozen visits, and today is visit 6. Here's where we were in the past, and here's where we're going to be in the future, and that's where everything fits together. So this element is really important, so you can see that Medicare, and because Medicare is saying this, we can pretty much assume everyone else is going to say, yeah, we want to see that information as well. And some already do. In fact, I think I've seen something in Optum, I think, in their guidelines that say that you need to document the visit number and so on. Regardless, it's just a good idea. Okay, and I would advise you, if you're not doing it, to go ahead and begin to state what the visit number is. So I'm going to illustrate this concept of the episode of care. I call it the episode of care journey, if you don't mind me indulging myself here. Because I believe that a chiropractic, or even any physical medicine, physical therapy, what have you, the episode of care is like a journey. And I like to compare this to a road trip I took, not this past summer, but the one before. Actually, it wasn't a full road trip. The deal is, I live in Utah, and I took my family of 6, I have 6 kids. We went up to Yellowstone National Park. It's about 6 hours straight north of us, okay? And you know, to plan a trip like that with that many kids, you gotta sit down, and you can't just hit the road. You gotta go, okay, we are starting here, just south of Salt Lake City, and we need to get to this point further north. Should we take the interstate, or should we take the more scenic route, or should we stay on the interstate? Except when we get up to Idaho Falls, should we veer off and go, because it looks like there's this cool natural phenomenon there. There's a cool rock formation we can go visit, and it might take us a little bit longer, but we'll go off and we'll check it out, and then we'll get back on. Or am I going to need to stop to feed my kids? Am I going to have to stop for gasoline, and refuel my car? What if there is a traffic jam and I have to find an alternate route? Okay, so I got to look at all these things. What if I have a flat tire, etc. Right? So you get the idea. So what this diagram is showing is that I have an origin in mind, and that's the initial eval right there in the upper left. I have an origin. With the chiropractic care plan, I do a great initial evaluation where I document exactly what the problem is, which is the diagnosis we're going to talk about towards the end of this presentation. I document what the problem is, I document what my plan is for that, and I say, in order to get this patient to a destination, Yellowstone, or in this case, you see the evaluation discharge on the far lower right. In order to get there, we're going to head south on Spinal Stenosis Road for a little while. So I'm outlining that plan. I'm going to say, when I hit the first intersection, I'm going to go ahead and turn left. I'm not going to go straight because it doesn't make sense, but I'm going to turn left because that's what I think this patient needs. So I would outline a plan that says, for example, we're going to begin with passive modalities, and we're going to do it for 4 treatments, and then we're going to begin to transition to active treatments with exercises, and that's kind of what represents this turn in the road, right? So that every T you see there is a treatment visit, right? A typical daily visit. And so I've outlined this plan, and in my plan I might say, so we're going to do this initial trial of care for up to, let's say, 4 weeks. A 4-week trial is pretty classic, and it's also supported by the literature. So I'm a fan of putting together 4-week trials for typical chiropractic patients. There may be exceptions, but I think most patients can fit into that 4-week trial. And then I get to that interim evaluation there that's kind of in the middle. And this is where I might pull off the road, right, and go to the gas station and pull out the road map again and take a look at it and go, okay, I had planned to go north. Did I go north, or did I take a wrong turn? Can I still go north, or do I need to change direction for a while? So it's at this interim evaluation when you stop and say, all right, when I started out on this journey, I made a goal to cover this many miles. Did I cover them or not? Or for a patient, I made a goal to reduce their pain rating from 8 to 5. Did I do it? Did I reach that goal? And then I will stop here. I won't go on yet until I say, you know what, I didn't reach the goal. How come? And I'll analyze it. As a provider, I'm obligated to state in my record, I expected to get the pain down to a 5, but I didn't. And here's why. patient didn't show up for 3 of their visits. That's why. Or patient fell down the stairs, and that's why they're not progressing the way I expected. Or maybe I reached my goal, and I can say, yep, I plan to get them from an 8 to a 5 on their pain scale in this first 4 weeks or 2 weeks or whatever the point is in time when you determine to do this interim evaluation. And I go, yeah, I reached my goal. So therefore, my original plan was I thought this would take 2 or 3 months, and I'm going to go ahead and continue on as I planned because everything is doing what I expected, right? Now, in this example, I've got an intersection there where I could continue to go straight on disc degeneration highway, or I could turn south onto neuropathy lane. And so the interim evaluation should show that the provider isn't stuck in a cookie-cutter plan, but that they're willing to adapt and make a change if it's indicated. If it's not, then you continue onward. But I've seen too many doctors' records where they'll do a middle evaluation. All they do is do a bunch more tests. And a lot of them are negative to begin with anyway, so I'm like, I don't need to see that again. And maybe some of them were a problem, and they retested it, and it's changed or something, but there's no statement about, hey, the patient's range of motion was really messed up before, and now it's getting better. Here's what we're going to do about that. I want to see that information in the interim evaluation. I need you to take a moment to say, we plan to get from an origin to a destination. We're in the middle somewhere, and we're going to keep going. Or we're going to stop. Maybe here the journey ends, and we say, look, we're not getting any progress. We thought we were going to, but there's something else going on here, so we're going to send the patient out for further testing or to see a specialist in another, another specialty. And so the interim evaluation is critical for showing progress in this episode of care journey. We're going through this journey, through this episode of care for a treatment, and we're trying to tell the story as most completely as we can. So let's say I hit the interim evaluation, I figure out what I'm going to do next, I update the care plan, maybe I change a few diagnoses if some things have resolved or I've got more information. And then I continue onward towards my final destination, which I call my evaluation discharge. Whichever of those paths I take, I want to end up at this point where I can say, yes, you've reached maximum therapeutic improvement. There's no more opportunity for change. They're not going to benefit from further care. So this is where we're going to go ahead and say our original goal was to get their pain from 8 to 5 by the interim evaluation and at least to a 2 or below by the discharge, because that's all I think I can expect. The 0 isn't realistic in this case, maybe. And this is where I take the time to evaluate that and say, yep, we did it, or no, we didn't, and that's okay. We're going to do a trial withdrawal and see if they qualify for chronic management or something. But there needs to be a discharge, okay, a point where there's an end. Payers really don't like the fact that chiropractors seem to never have an end in mind with their patients. They either treat them forever or they don't have a plan to get them to a specific destination. They just treat the patients until they leave. That's like driving in around a traffic circle forever, or heading north on the highway, not knowing I'm planning to get to Yellowstone, just going north. And that isn't what payers need to see. They need to know that you have a destination in mind, and then when you get there, you pull out and you see the geysers, and there's bison wandering around. If any of you haven't been to Yellowstone, I highly recommend it. Amazing place. It's a little crowded, but it's beautiful, and there's some great things to see there. So I want to get out of my car and look around and go, yes, this is where I wanted to get to. Or, this isn't quite what I planned, but take a moment in your assessment to just mention that and provide that story so that anyone else from the outside looking in can now pick up your record, and it's just like looking at this map. And I can see the whole story from the beginning to the end, and I know what happened in between, and I know why you did certain things. And that's the concept of the episode of care journey, okay? It's a bunch of treatment or daily visits that are interspersed with some significant evaluations to monitor progress. Also, please note that these treatment visits aren't going to look the same as an evaluation visit. And if I'm your auditor and I come in and say, hey, I want to see that visit in the middle of disc degeneration highway, I want to see 2 of those visits, you can come to me and say, well, sure, you can look at those, but to get the whole story, you really need to see my initial evaluation and my interim or my discharge evaluation. Otherwise, you're not going to understand the journey. You're looking at a point in time, and you can't see where I'm headed and where I started out. So if you take great records and you create great evaluation visits, then even if a payer only asks for a couple of the treatments, you can provide them with those evaluations. But don't do it if you have lousy evaluations. If they're great and you know it's going to tell the story, then give it to them so that they are forced to look at them. What I've been told is that you should only give them exactly what they ask for, but I would suggest you give them more than that if you know you've done a great job, okay? If you've really told the story, you had a great care plan put in place, you monitored that care plan, you evaluated it, you told the story as you went along, then you should definitely get that to them, okay? And that's that's kind of the gist of this whole episode of care journey. So let me just see here. It looks like I might, just in the interest of addressing things, I'm going to address this question that just came in from Rebecca. She says, how do you avoid getting red flagged when billing that many evaluation codes in a treatment plan? All right, Rebecca, so let me clarify what I'm saying here. Let's say that this episode of care journey represents 8 weeks, okay? 8 weeks. So during these 8 weeks, in this example, let's say I billed, 15 visits, okay? And what I'm proposing here is that I might bill a 99203 at the initial evaluation, and at the interim it might be a 99213, and the discharge might be a 99212. So I'm proposing that we might bill 3 evaluations throughout this care. If the payer says, hey, this policy only covers 1 evaluation a year, or some ridiculous thing like that, this is me, all right, not you guys. You have to deal with the patients, but here's what I'm going to say. Well, I need to do evaluations. It's the standard of care. It's how I monitor my patient's progress. So I'm going to have to charge the patient out of pocket and tell them they have lousy insurance. That look, in order to provide proper care, I need to evaluate you at some point. I can't not evaluate you. Now, if you evaluate them in a way that's not significant and separately identifiable, then you can't bill a separate E&M. If you do a really minimal evaluation that's considered part of an adjustment, then you wouldn't bill it separately. But I believe that a classic interim evaluation, discharge evaluation, are significant enough to be billed separately. And I think the insurance company should pay you for it. I'm not saying they will. I think they should, though, because I think it provides a standard of care that is reasonable. So that's my opinion on that one. I hope that answered your question, Rebecca. Let me share with you another snippet from a denial that I've dealt with. This was from another client. I can't remember the insurance company. This one might have been Cigna or United Healthcare. I don't recall. But I just highlighted the key words because I bet you everybody on this call has received a denial like this. All right? I bet you all of you have seen this. They just said, look, your care wasn't medically necessary. Whenever I do my live seminars, I just got back from, where was I? Oh, Illinois last week. I did a seminar there, and I'll be doing one in Denver in the next few weeks. I like to ask the audience, how many of you have ever gotten a denial and they just said it wasn't medically necessary? All the time, right? And this is just one example. That's just a snippet from a denial that I was working with a client on. So the question is, what is medical necessity? How do you define it? And some payers will give you a definition and others won't, and they're just kind of vague about it. Really what I want to bring out to you is how do you prove medical necessity? What is it? Is there a universal formula we can apply that should work for pretty much any payer? I've given you a quote here from Medicare that says what they believe medical necessity is. This is actually from the Social Security Act. But basically, medical necessity is when you give a service that helps improve the function of a part of the body that isn't working. So can we show a loss of function, improvement of function? And if so, how do we do that? What has to be there? So what I've come up with is this medical necessity, this chain, if you will, this chain of medical necessity. And I've used this concept because I believe that chains are a good example where if you have all the links together and they're all strong and solid, that you're going to have a much more robust tool. A chain that is linked together and all the links are present and they're solid, it's going to be stronger. Now, having said that, I'm going to give you 6 links right now, and if you're missing 1 or 2 of them, you might still be able to prove medical necessity, but the odds are a lot better if you have all 6, okay? So here are my links in the chain of medical necessity, and I'm going to elaborate on all of these, and you'll be able to rewatch the recording of this presentation as well. So take notes if you wish, but you should be able to come back to this. I believe the first link in the chain of medical necessity is history of onset, meaning I have some sort of explanation of beginning to this problem that needs treatment. We can't always do that, and I'll explain what to do in that case, but it makes it stronger if you do have a history of onset. Okay, that should tie directly to the patient complaint. So here's a classic example. The onset was a car accident. The patient complaint is their neck hurts. Pretty much anyone can understand that someone who's been in a car accident is going to have neck pain, and so those make sense. Those links go together. Now, if someone says, I don't know, I was working out in my yard, and I was just working down on the ground, and suddenly my ankle began to hurt a lot. I didn't twist it. I didn't do anything, and to me that kind of creates a dilemma. I don't see the link between the onset and the complaint, you know. So I want you to understand those things should relate to each other. The third link in the chain are exam findings. I've seen providers who like to do these cookie-cutter exams and say, well, I do these 15 orthopedic tests and I do this range of motion here. I don't care what your complaint is. That's my exam. And as an auditor, I don't care what your exam is. I care about you giving me objective findings that explain the complaint, that tie back to the onset. So they should link together, okay? Number 4 is the diagnosis. I want you to give me a diagnosis that matches exactly what you found in the exam. I don't want you to say, well, I know the payers pay better if I diagnose radiculopathy, so I'm just going to use that diagnosis all the time. You better have exam findings that support radiculopathy, such as orthopedic findings, as well as perhaps an MRI, just as an example. So the diagnosis is a critical link in establishing medical necessity. The 5th link I put in this is the treatment plan. I want to see a really clear plan. Now that you have a diagnosis, I want a plan that says, okay, they've got radiculopathy, here's how I'm going to address it. We're going to do these manipulations, we're going to do these exercises, we may start with some of this electric stim, and here's how often we're going to do it, and here's the purpose. I'm going to do it because I believe this will reduce the inflammation, I believe this will help correct the alignment or whatever the problem is. And then finally, number 6 is super important, it's progress. Can you prove progress? Can you show me, if I look at your records, can I see that the patient started somewhere and ended up somewhere else? Like the journey, the episode of care journey we just talked about. Again, too often the records just kind of disappear. The patient stops coming in and the doctor never takes the time to say, well, we had a goal of changing the outcome assessment score from this to that. And then you never discuss it. You never show me that. So progress is really important. I'm going to elaborate on all 6 of these, okay? We're going to take a minute to expand upon them right now. I want to let you know that I tried to design this in such a way that you could pick any one service. Just pick any service you've provided to a patient. Let's say it was exercises, therapeutic exercises, or it was a chiropractic manipulation. I don't care what it was. Pick one service you did and ask yourself, if you gave me your records, could I find all 6 of these links for that service? Just for that individual service, not just necessarily for a day, a treatment where you did 3 or 4 services, but pick one service at a time and apply these 6 things and say, if I test it out, can I find evidence of all 6 of these for that service? And that's why I think this is useful for you. I want you to be able to apply this to to your services. Pick the last service you delivered before this webinar and ask yourself if it's clear, if I look at the record, if I can see all 6. So let's start with history of onset, okay? History of onset is, where it started. Now, tell me why the patient has a complaint. Now, if someone's been in a trauma, Medicare even says, we want you to document the mechanism of trauma. Well, you and I know that most of your Medicare patients don't have a mechanism of trauma. They just show up because they're not feeling good. And there's no event or incident, and it's hard to document at onset when they just say, well, I don't know, it's just gradual. So here's some advice for you, a tip for you to try to document some sort of history of onset for chronic patients. For those who say it was insidious, it just kind of started, I would encourage you to really drill those patients and say, well, then why did you show up today for this? Why didn't you show up a week ago? Why didn't you wait another week? What was it that made you decide now was the time? And if you can get them to pinpoint some reason, now you've got a bit of a history of onset for a chronic problem. So mechanism of trauma is easy to specify for acute problems, but for chronic problems it's a little harder. So ask them why now. And that may help you come up with something. And if you can't come up with anything, then you don't have a history of onset. And that's okay. It's not ideal, though. You're much better off if you can prove a history of onset, okay? And it's documented well. Now, the next 2 links are the patient complaint and the exam findings. And I just listed them here together because they really just have to relate to each other. The exam findings should revolve around the complaint. And if you do let's say the patient complains of their neck, but you love to examine knees. You can examine the knee all you want, but if it has nothing to do with the complaint, then it doesn't help support medical necessity, all right? You need to do an exam that ties to that complaint. This is where we can establish functional loss. As you may recall, the definition of medical necessity by Medicare includes functional loss and functional gains. So in the history, you get some information about their activities of daily living, or ADLs. In the exam, you show functional loss through the examination you perform, and you document that to help support the need for ongoing care. The 4th link in this chain is the diagnosis. And again, I'm going to emphasize this a little bit more after we finish talking about the chain of medical necessity. The diagnosis should provide a plausible explanation for the symptoms. So again, if the patient says my neck hurts and your diagnosis is subluxation complex of the left knee, I don't get it. I don't understand the link there. And if you just say, well, someone told me that these are the 3 best diagnoses for getting paid, so those are the ones I always list. don't do it. You should only diagnose the things that you have determined and supported by your examination and in your documentation. That's why you're a doctor. That's what you get paid the big bucks to do, is to figure out what's wrong with the patient, identify the problem, and so make sure you understand how to support a diagnosis. As a side note, we have, Chiropractic, we have these diagnosis and documentation cards where we take conditions and say, here's what you should document to support that condition. So it's something to consider. Something you need to understand is that the clinical criteria from the history and the exam should match up with the diagnosis. This record that I started auditing this morning, that I need to finish when we're done with the webinar, I can see that they've got a nice, big, thorough clinical criteria. They've written a really long subjective and objective portion of a SOAP note. And then I read their assessment, and it doesn't even say what the diagnosis is. And I don't get it. To me, the assessment needs to explain, all right, based on all the clinical criteria I just gathered, here's what's up. To me, that's what the A is in a SOAP note. It's taking all the clinical criteria and then stating what the heck you found. Okay? Here's a question from Tom. He says, how is this for a reason? I'm leaving for Arizona in 2 weeks and want to feel better for the trip. He said he just had this one yesterday. All right, Tom, so I see where you're coming from. At least you have sort of a thing. That's for the onset, right? Well, I'm coming in because I want to feel better. So why now? You know what? That's better than nothing. I don't think that's really strong, but it certainly gives you a bit of an argument. Say, look, the onset, the reason is they weren't feeling well and they need to get in better shape because they know they're going to be spending some time traveling and it's going to be difficult to manage. I don't know. I mean, yeah, do it. Document. It won't hurt. I don't think it's as strong as they fell off a ladder. Like, that's a really great onset, but not for the patient, of course. So do your best with that. You know, that's a good question. And I understand that it's not easy to always identify a history of onset, but I'm telling you that if you can, it's better. So do all you can to identify one. The fifth link in this chain is the treatment plan. And gosh, I have a couple hours of presentations just talking about treatment plans. So here's a couple of high points about treatment plans. When it comes to chiropractors, if they can just improve the treatment plans and use them properly, I think it will fix 80% of the problems they get when they get audited. Okay, treatment plan is so critical, and it's done poorly a lot of the time. So let me help you understand the high points here. The treatment plan should be appropriate for the diagnosis. And what I'm saying there is, if you diagnose a patient with cervicalgia, and that's all you diagnosed them with, and by the way, that's not a diagnosis, it's only a symptom, but all you say is cervicalgia, and then you say they need 30 visits, I'm not going to, if I was your reviewer, I'm not going to allow that. I'm going to say, no, cervicalgia, heck, you can treat cervicalgia with a bottle of ibuprofen and only spend $15. Why should I pay you hundreds of dollars? Now, if you come to me and say, well, here's the diagnosis, it's cervical strain. They have strained the muscles and they've been damaged, and I got to do some adjustments and some rehab exercise and all this stuff, then as your payer, I go, okay, I get it. That treatment plan makes sense. And I've seen far too many chiropractors provide the exact same treatment plan for every patient, regardless of the diagnosis. And it bugs me. I think that some patients need more treatment and some need less. And you should have that flexibility within your care. Now, care that's given just because of your technique or your philosophy, or it's just routine because your office has a certain piece of equipment and you always do ultrasound on everybody all the time because you have ultrasound, that is not necessarily medically necessary. That specific service, like ultrasound, you better prove why that was necessary and what the patient had that necessitated this treatment. Regardless. Technique, I'm a full spine doctor, so I'm going to bill a 98942 and always do a full spine. If the other links in this chain are not present for every segment in that patient's spine, then you don't get to bill for a full spine manipulation. Treatment should transition from passive to active care. I have a statement from Aetna again that says, look, we understand the value of modalities like passive treatment like e-stim or ultrasound, but we recognize that they're only useful in the first 4, maybe 8 weeks of care. And at that point, care should transition to active treatment such as exercises, therapeutic procedures, because that keeps the patient from becoming dependent on the passive modalities. So if you're one of these folks who likes to do e-stim on a patient for 30 visits in a row, if I was your payer, I'd only pay you for the first 5 to 10, honestly, because I don't think you can prove to me that passive modality still has therapeutic benefit to them. Now, if you do that for 5 to 10 visits and then you're working them hard on these exercises and rehab and you're pushing them and you're giving them new stuff and it's developing through care and you're showing how it's giving them progress, that I would pay you for. All right? That's passive to active. And then finally, avoid cookie cutter care. Don't do these treatment plans the same for everybody. Some patients are older, some are younger, some have worse problems, some have better problems, some have lots of comorbidities and complications, and others don't. So avoid cookie cutter care. Make your care plans unique to each patient. For example, maybe John's pain starts at an 8, but Susie's pain started at a 5. The care plan goals could say for John, you could say, I want to reduce pain, and you could say that for both of them. But how about instead of that, you say, for John, I want to move it from 8 to 4 within this period of time. And for Susie, I want to go from 5 to 0 in this period of time. Those are unique care plans. Those are goals, unique goals in the care plan. You know, and because John's pain's higher, I might do E-stim a couple times more. That kind of stuff. That's what I want to see when I review your records. The final link in this chain is progress. So as we go through the episode of care and you look at those little treatment visits or the re-exam, the interim exam, this is where you show progress. Goals need to be specific to each patient and measurable. As I mentioned, you mention the specific patient's findings and you make a goal around that. Measurable goals are ones that use numbers. So reduce pain, increase range of motion, improve strength. Those are lousy goals. You can use those goals, and I think that you want to do that for patients, but I want it to be specific for that patient and measurable. Assign a number. Tell me how much you want to reduce the pain. Tell me how much you want to change their range of motion. Tell me the time frame. So I can look at those goals later on and see if you've made those changes. Outcome assessment tools are the best way I know of to quantify functional progress. The single best way. Payers like them. You take a bunch of subjective information about their ADLs and you assign numbers to them. That's what outcome assessment tools do, like the Oswestry or the Functional Rating Index. And so I'm a big fan of these. And if your patient's score starts at 50 and goes down to 25, you've just proven to me there was progress. Now, if their outcome assessment score doesn't improve, but you think they've still progressed, then you better give me some other reasons. So another example of some other reasons might be, well, I can show quantifiable change in the range of motion, or I can identify that they have reduced their dependence on over-the-counter painkillers. Those, to me, also show progress. They're not nearly as powerful, though, as an outcome assessment score. And these goals have to be evaluated and updated over time. It's just not enough for you to say, I made a goal. It was back here. I said the goal was to reduce their pain. And then 8 weeks later, I said their pain was a little better. Like, that to me isn't enough. If you say the pain started at 8 and I got over to get to 5 and then later down to a 2, evaluate that goal. And at 8 weeks, I might say, you know, I thought they'd be down to a 2 by now, but they're still up at a 4. I think it's because of the underlying diabetes. They're just not getting there, and that's why. And as such, I feel like we can't get any more progress, and we're going to release them from care. You know, I want you to take a moment to state that, and that kind of statement is not going to show up in every patient chart. Only the one who happens to go from an 8 to a 2 or an 8 to a 4 and has diabetes. I mean, so that's why you customize these records, and you provide information that's specific and useful. Okay? This information is all in Chapter 4 of the desk book. We just released this week. We started shipping the 2018 desk book a couple months before the end of the year. You're welcome. If you don't have one, you should get your copy. Jeff can get you a special deal on those. So here's the chain of medical necessity. There are 6 links in the chain. I believe that if you were to pick any single service you've delivered in your office and you could prove these 6 things for that service, then most payers would have a really hard time telling you it wasn't medically necessary. All right, so that's my advice to you, is to look at these 6 things and see if you can prove all 6 of them, hopefully all 6, for any service you give. And if you do that, you're in good shape. You've got medical necessity, in my opinion. All right, and I've been influenced by these documents from the payers, from Medicare standards, from state boards, what have you, that I've worked with. That's where I came up with this chain of medical necessity. Okay, so that leaves us with one other topic to discuss today, and that is ICD10 and diagnosis in general. This is my own list again. This is not from official policy from anybody. This is simply my list, because here's a question I get asked all the time. Well, what's the best diagnosis? Which one's going to get me paid the most? You know, what's the best one? Well, what I've done here is I've said, okay, let's take the kinds of things chiropractic patients have, let's dump them in a bucket, and then let's identify, you know, which ones are more serious than others. There's an ICD10 guideline that says that you should code for the most serious injury first. There's another one that says that you should code for the primary reason for the encounter first. And then Medicare, in many jurisdictions in the past, has listed ICD-10 codes and ICD-9 codes, and they've grouped them and said, well, these ones are better for longer-term treatment, and these other diagnoses are more appropriate for shorter-term treatment. So to me, that says that some diagnoses they believe are more serious than others. So I've used all that information and came up with this simpler list for you. I believe that the most serious condition chiropractors treat are nerve-related problems, and so I put that at the top. And what I'm suggesting is if you had a patient with all 8 of these things going on, that the first one you should list is the nerve one. The second most serious thing chiropractors treat, I believe, are acute injuries, in my opinion, so that's sprains and strains. And the third is structural problems like degenerative disc disease. And then I've listed functional diagnoses like difficulty with certain activities of daily living. And then I push down the soft tissue and symptom problems further down the list. Here's why. I believe that if your diagnosis is a symptom, like neck pain, that you have not used any clinical skill. Therefore, I'm not going to pay you as much. It takes no skill to simply restate what a patient said. And neck pain and muscle pain are lousy diagnoses. They don't help establish that there's a serious condition. They simply are a restatement of what the patient said when they showed up. And so I don't think you deserve to get approval for many visits unless you, as a diagnostician, can come up with what the problem is and put together a plan around that. Now, the last 2 on this list, complicating factors and comorbidities and then external causes, are not as important. In fact, they may not even need to be coded, per se, when it comes to ICD-10. However, they can be. The guidelines allow us to code for complicating factors. They say that you should code for everything that affects patient care management and treatment at a given encounter. So if you feel that diabetes affects your management of the patient, you could toss that diagnosis code on there and put it at the very end if you want to. However, I'm concerned payers won't understand that. They'll think you're treating diabetes. So you might want to keep it off, not listed on a claim. You just document it really well. But I'm telling you, if you wanted to put on a claim, you're entitled to do so. You might get a denial, then you have to fight it, and you can quote Section 4, Paragraph H of the official ICD-10 Guidelines, which states that you can code for comorbidities, complicating factors. Then the final one I've got here is external cause codes. If you don't use these, you don't know what I'm talking about, don't worry about it. They're optional, although a lot of people, especially if you do personal injury work, you tend to use these because these are codes that tell about the place and activity the patient was engaged in when the injury occurred. And so they can be helpful to tell the story, but the guidelines tell us they go last when you list other codes, all right? So that is how I would advise you to list your ICD-10 codes. Now, some of you are saying, wait a minute, what happened to the chiropractic subluxation? Where'd it go? I didn't put it on here on purpose. I think that it maybe fits around number 4 or 5 in there, maybe 3. You could stick it in there, but here's the deal. If a payer tells you that the segmental dysfunction diagnosis must be listed first, which is what Medicare says, then list it first. But after you've met that payer guideline, then follow this hierarchy. Okay? And if you don't have a payer guideline that says the subluxation has to be listed first, then don't list it first. List it wherever you think it fits within this hierarchy, which, again, might be 3 or 4. Okay? That's my advice on that one. So here's some general ICD-10 tips for you when establishing your diagnosis. You should follow ICD-10 guidelines. If it's been a while and you don't remember what excludes 1 means, or you don't understand the abbreviation NOS, then go back to the basics. Pick up the ChiroCode ICD-10 book or the ChiroCode Desk book where we've reviewed all the guidelines for you in an easy-to-read format with examples and stuff, so you can check it out. If you are coding for symptoms, add the phrase due to for better specificity. So I kept telling you, don't diagnose cervicalgia. That's lame. Lumbago, that's not even really a diagnosis, right? But here's what you do. If that's what you're going accustomed to, here's how you fix it. You say, this patient has lumbago due to, and then you as a clinician come up with the reason. What's causing lumbago? Maybe you can come up with one of those much better diagnoses that are structural or neurologic or something, and those will establish medical necessity because now you have a definitive condition to treat. Okay? If you want to list complicating factors, go for it, if relevant. I mean, at the very least, they should definitely be documented. And then I want you to learn to document a diagnostic statement or clinical impression that matches the code requirements. I don't have the time to read that in its entirety with you today. You can read about it or watch for a webinar where I explain it in greater detail. It takes about half an hour, 45 minutes to just explain the diagnostic statement. But I want to give you a little bit of background on it before I move on. And we move to the Q&A portion of this presentation. But a little side note, I encourage you guys to keep submitting your questions. I see a couple more that have come in that I'm going to save for the end. Okay, so if you're thinking of things as I'm talking, go ahead and submit those questions, and I'll see them, and we can talk about them, and we'll let you do them verbally too. So what I've got on my screen now is a screenshot out of the official ICD-10 guidelines. This is section 1A, paragraph 19 of the official ICD-10 guidelines. This guideline was added last year, last October, and so it was new to help clarify some things. And what I want to point out from this guideline is the first sentence says, The assignment of a diagnosis code is based upon the provider's diagnostic statement that the condition exists. And what that means to me is if you're the provider, you better create a diagnostic statement that says the patient has this problem. Because again, the note I was just looking at today, I told you, it doesn't even say what the patient has. They list some diagnosis codes up above on the note, but they don't. The provider has some generic statement that clearly could work on any record. And then the final sentence in this little paragraph says, code assignment is not based on the clinical criteria used by the provider to establish a diagnosis. And what that means to me is, let's say the provider writes down, the patient pees a lot, they have to drink a lot, I tested their blood sugar and it's kind of high. That is clinical criteria, right? And most of us would go, oh, well, that's diabetes. You need to go out and create a diagnostic statement that says, based upon the clinical criteria, I believe this is diabetes. That's what I'm trying to tell you is, as a chiropractor, you should document the diagnosis, the condition, based upon the clinical criteria that you stated up above. All right? So here's an example from our book. And again, I'm not going to go through it in great detail, but what I did in this example is I got the history and the exam findings listed up there, and then I've got 6 diagnosis codes I've tossed onto this case. 2 of them are external cause codes, so they may not be as important, but I threw them in for fun. And at the bottom, I took the clinical criteria from the history and the exam and rewrote it and summarized it as a diagnostic statement. So the diagnostic statement here was very carefully worded to include the results of my conclusion based upon the history and exam up above, and I used the words from the code descriptions to influence my word choice in the diagnostic statement, which makes it a very powerful way to convey to an auditor that here's what's wrong, right? Here's why the care that follows is necessary. So I have another presentation again where I highlight each code and we audit this note and we talk about it, but I just want you to see this and think about it. You can take a screenshot of it and or rewatch the recording or get a copy of the book so you can read up it. It takes about 5 to 10 pages to explain the whole thing, okay? So that's the diagnostic statement. Now, everything we just talked about is in the brand new desk book, chapters 4 and 5. It's kind of spread out there. We redid a bunch of both of those chapters this year, added some really great new stuff to help you make your life easier. The takeaway from what I want to share with you today was I want you to understand the episode of care journey, which was the map we were looking at earlier, and how outsiders are looking in at your care as an episode, or we want them to. Even if they're not looking at it that way, they just say, I want to see visit 2. You go, no, not visit 2. Here's visit 2 of 10, and here's visit 1 and 10, so you can see where 2 fell into this. And then I wanted you to learn to apply the chain of medical necessity. I want you to try your best to document all 6 links in that chain whenever you can to prove that the care is medically necessary. If a link is missing or is weak, you might still be okay. You might still be able to prove it. But if you can get all 6 of them, then you are doing a better job. And then we talked about using a solid diagnostic code hierarchy and creating a diagnostic statement and its role in proving medical necessity. All right? So that brings us to the Q&A portion of this presentation. I might flip back and forth through the slides if some of your questions could be better illustrated if I had to go back. But Jeff, if you want to jump in now, I'm going to go ahead and address the questions that have been typed in, and we're going to try this this unmuting. But I'm going to warn you guys, when I unmute and there's a larger group, there's always somebody who has dogs fighting in the background or construction equipment or what have you. So I'm going to unmute you, or I think I'll be able to give you the opportunity to be unmuted, but I want you to be sensitive. If you know there's background noise and you don't have anything to say, then go ahead and just remute yourselves. You can click on the little microphone icon and keep yourself muted. Click to unmute. Here we go. Trying to figure out if I can do it all at once. No, I'll just do them one at a time. Sorry, I'm going to unmute everybody. So you have the privilege, but you can remute yourself if you know that you want some. You're noisy or what have you. Hang on. Well, I can hear a few of you here with us. Just a moment, I'm trying. Don't mute yourself yet. I got to get through the whole list. I'm doing them one at a time. Self-muted. Okay, so I think you guys are okay. If anybody there wants to be unmuted and you're not, I'd say speak up, but that won't do any good. You can submit it in the chat, perhaps, or submit a question and say, hey, I want to be unmuted. Before anyone else speaks, I'm going to address a couple of questions that came in that were typed in. And Jeff, you're here? You're with me now? Well, maybe Jeff is muted.
Yeah, I'm there. Go ahead and do that, and then I've got a couple questions for you as well.
Great. So let me go ahead and address the couple of them that have been typed in first, just to kind of we'll go through. We have a few minutes, so we'll be able to I think answer all your guys' questions. This question is from Tom. And he says, I can't begin to tell you how many times the outcome score has gone up after 30 days, but the patient states 50 to 60 to 70% subjective improvement with reduction in pain scales. I hear you, Tom. I've heard this before, and here's the deal. The outcome assessment score is the best tool you have for showing medical necessity. I think it's the greatest way to do that, but I know it doesn't always work in your favor, and which is why I think you should be aware of other. You can emphasize. In fact, here's what you would do at that reassessment. If I flip back through my slides here, I say back here during the journey, I would say, look, here's some things that show evidence of progress. The patient's subjective complaint is much, right? So I'm looking at this map again. You know, I know the outcome assessment score didn't improve, and here's why I think that is. I think it's because the patient doesn't know how to answer the questions, or because, come up with a reason, an explanation that you believe is valid, and try to focus on the other aspects and downplay that as best you can. I know that things aren't always going to line up perfectly, but that's my take on the outcome assessment score when it doesn't. Right? So, Tom, before you get a chance to follow up, let me answer this one question from Paul. He says, if the patient states they have tingling in an extremity, but there are no positive objective findings such as dermatome testing, can we still use radiculopathy codes? Paul, good question. Radiculopathy codes, it's M54.3, I think. Those are the codes that are, technically they're symptom codes. They're codes for radiculopathy, and you can report them if you believe you have subjective findings to suggest they have radiculopathy. And then if you get objective findings such as an MRI that says there's a disc, there's a new code, there's a different code that says radiculopathy due to a disc disorder. There's also one for radiculopathy due to spondylosis. So, in other words, you can use a more specific radiculopathy code with a cause if you know it, but if you don't know it, then you just use radiculopathy and report that. So I think, yeah, in my clinical opinion, there's no positive objective findings. I mean, I'd like to see a positive Sperling's test or foraminal compression, for example, at least. And if there isn't that, and you believe the patient's maybe making it up, there is another code for just paresthesia. You can say for a symptom code, it's an R code. I don't know off the top of my head. That's how I would handle that one. Okay, those are the typed-in questions. I'm going to go ahead and, I don't know, Jeff, do you want to go first before we let the other folks have a chance to speak up?
Yeah. We see with Noridian as our Medicare administrative contractor. We know on their proposed LCD that they have those same changes that you noted earlier, and we know in conversations with Noridian's auditors or reviewers that they really have really emphasized treatment plan and objective measures in the documentation, and it looks like by adding the requirement of the fourth visit of 7, that they're really pushing providers to have a treatment plan and objective measures showing how the care is helping or not helping the patient. What's your recommendation on incorporating treatment plans and objective measures for private payers as well?
No difference. In fact, I don't care if it's cash, personal injury, Blue Cross, Medicare. I think you should hit a standard that you can do, that you don't feel like it's too burdensome from an administrative standpoint, that you can follow and make it the standard for all patients, no matter who the payer is. Because the quotes I was showing you here were from private payers, most of them, so they're looking for the same stuff. What they do is they let Medicare set the trend, and then they follow. So if Medicare's saying it, you should just make it a standard. That's my opinion.
And then the other question I have is, you've been involved with CCGPP with those guidelines, and I've been try to emphasize them with my clients because it shows, it gives you some examples of treatment plans and care algorithms. Do you have any recommendations or suggestions as to how doctors can incorporate that information into their
so those spinal care algorithms influenced my design of this map here. And they're outlined in Chapter 4 of the desk book. You can access the article for free from JMPT. I think it's a great way to say, look, I have evidence to support why I set the care plan this way. And if you can use evidence-based guidelines and say, the guidelines suggest that you put together a 4-week trial of care with an evaluation at the midpoint. If you do that, then you have some support to why your care was necessary, and I strongly encourage you to do so. Implementing it isn't that hard. You might just add a line to your first visit that says, and we use this reference, and you put the reference for the article in there. It's going to make it a lot harder for a peer reviewer to deny what you're saying when you've used evidence to support it. So I have another presentation where that's taught, and I think it's in I think it's in our webinar archives, or if you have a ChiroCode membership, you can watch the recording for that one, or just read the chapter, or get the article for free and read through it. You don't have to read the whole article. Jeff can probably give you the reference, but it's really the only last 10 pages that are useful, so you don't have to read a ton.
Okay. So does anybody else that's still with us, anybody have any questions, specific questions for Dr. Gwilliam?
See, a few of you are unmuted, so I figure you have got some exciting thing you want to ask, or you got me here. But if not, I'm good if you guys are good. I hope you found this to be helpful. And we provided you with some information you can implement. I've had people tell me, look, you're telling me way too much. If I start doing that, I got no time for patients, right? All I'm doing is paperwork. And all I'm telling you is ideal. If you don't want to do some of the stuff I'm talking about, choose what you don't want to do, or it's too impractical. But I'm letting you know what would be the best. Hit this standard, figure out how to make it smooth so it doesn't interrupt your office flow, and you won't have to worry about third-party payers. They won't bug you because you'll be hitting what they're looking for, you know? That's what I hope you guys got out of this.
All right, anybody? Now's your chance to ask a question.
All right. I think that means you're free to go.
Yeah.
We'll
all right. Just the last thing is that I will send out the test link to all the attendees if you do want to get a continuing ed credit in South Dakota for both doctors and CAs. You can take the 6-question test and just have to get at least 5 out of 6 right. So that will come out. Will come out shortly once we get done. So thank you, Dr. Gwilliam, for your time and information.
Thanks, Jeff. It's been a pleasure.
All right. Have a good afternoon, everybody.
Bye-bye.